Hey, my name is Amelia Godfrey. I'm a fourth year pharmacy student at UMKC School of Pharmacy. For my topic of my AmCare disease state presentation, I wanted to focus on thyroid disorders. This is something that didn't stick with me well in school other than maybe dosing levothyroxine, so it was a great review for me and I hope it is for you as well. As far as endocrinology goes, thyroid disorders are much less common than diabetes, but they're very important because thyroid hormone regulates metabolism and is involved in the functioning of numerous organ systems. So today we'll start by looking at an overview of thyroid disorders. First, we will talk about the epidemiology, the pathophysiology, assessing thyroid disorders, and the guidelines to look out for thyroid disorders. Then we will jump into hyperthyroidism, managing chronic and acute thyroid storm. And then finally, we'll talk about hypothyroidism briefly, as far as chronic hypothyroidism, hypothyroidism in pregnancy, and then managing acute myxedema coma. The lifetime incidence of any thyroid disorder in the US population is about 12%. Out of this, women have 5 to 8 times higher risk than men for developing any thyroid disorder. And in fact, 80% of patients with low thyroid are women. The scary statistic to me is that up to 60% of patients are unaware of their diagnosis. This means that there's a long way to go as far as evaluating patients for thyroid disorders. But a lot of the guidelines don't recommend screening, and if they do, it's very inconsistent from guideline to guideline. Today we'll be looking at the American Thyroid Association guidelines, which recommend screening in adults over 35 years of age every 5 years. Other guidelines focus on older adults, and especially women, and then some guidelines say that there's insufficient evidence to show that screening is even recommended. Now let's look at the hypothalamic pituitary thyroid axis, which explains the pathophysiology of thyroid disorders. We'll see this diagram a few times throughout the presentation. In this diagram, we start with the hypothalamus in the brain or on the top left corner. The hypothalamus releases thyrotropin-releasing hormone, which stimulates the pituitary gland to release thyroid-stimulating hormone, also known as TSH or thyrotropin. TSH stimulates the thyroid gland to produce T4, also known as thyroxine, and a small amount of triiodothyronine, or T3. T4 is the precursor for T3, and in the periphery, in the bottom right corner, you can see that T4 is converted to T3, mostly in the liver, with the use of iodide. Iodine from our diet is oxidized and then absorbed into our thyroid. That's how the T3 is made in the thyroid, and then iodide is also used in the periphery to create T3. T3 is much more potent, but T4 has a longer half-life, so it's more useful as a marker of thyroid function. T4 and T3 are transported through the blood by carrier proteins to the thyroid hormone-sensitive cells, and these cells respond by regulating various metabolic processes. One reason why thyroid disorders often go undiagnosed is because the assessment of these disorders is often difficult because patients typically present with complaints of nonspecific symptoms. Some of those include fatigue, muscle aches, and weakness. These all overlap between low and high thyroid levels. And then some of the other symptoms that you can see are GI upset, such as diarrhea or constipation, depression or anxiety, high or low heart rate. All of these are very nonspecific and could match various disease states. So when you have a patient who has these symptoms, it would be prudent to order some labs, specifically free T4 and TSH. The other thing that you can use are these symptom scales, such as Wayne score, the Billevich score, or the thyroid symptom questionnaire. I read a review about these different scales, and the authors commented at the end that basically the utility in these scales is to teach people about the different symptoms of thyroid disorders rather than to predict prognosis or to screen the patient for thyroid disorders. So take these with a grain of salt. Also note that TSH will change before T3 and T4 levels and is often thought to be more specific than the thyroid hormone levels themselves. The limitations to this method is that if a patient has non-thyroidal illness, is frail, or is very elderly, their TSH levels may be falsely elevated or low. One trick that I like to use to remember the symptoms for high and low thyroid is low equals slow and high equals fly. Low thyroid hormone slows everything down in the body. It slows your metabolism, while high thyroid hormone puts you into fight or flight, which means everything is ramped up and your metabolism increases. So that's a great way to remember the different symptoms between the two. Before we go any further, I want to show you where I found my guidelines. So today I'm using the American Thyroid Association guidelines, also known as ATA. And I have 3 different guidelines that I'm referencing today. The first one is about hyperthyroidism, and it was published in 2016. The second one is hypothyroidism, published in 2014. And then the third one is about thyroid disease and pregnancy, published in 2017. These are all pretty recently updated, and they are pretty well vetted. ATA is one of the major organizations for thyroid disorders. And here you see a screenshot of the website if you need to find how to find those guidelines. They were free online. Let's jump into hyperthyroidism. So here are the symptoms of hyperthyroidism. And again, remember that this is when we have ramped up metabolism, and my mnemonic here is high equals fly. So patients are going to have heat intolerance, high heart rate, agitation, tremor, diarrhea. Females may have light or absent periods, and you may see exophthalmos, which is the protrusion of the eye. Patients also might complain of thinning hair. So here's our diagram again. This time let's look at hyperthyroidism. The most common cause of hyperthyroidism is Graves' disease, which is an autoimmune disease. In Graves' disease, there are autoantibodies that attach to and stimulate the thyroid to release T3 and T4. Because of the negative feedback loop, this then causes the pituitary gland to release less TSH. So you have low TSH and high T4 in hyperthyroidism due to Graves' disease. When this happens, you have an excess of thyroid hormone that's transported in the blood by carrier proteins to those thyroid hormone sensitive cells. And because you have an excess, we have an increase of metabolism. So we have those fight or flight symptoms. Before we delve in any further, let's take a look at a patient case. HT is a 28-year-old female who comes to your clinic for chief complaint of hot flashes, and she's worried about early menopause. You can see her vitals here. One of the most important things is that her weight is down 15 pounds in the last 7 months. Her blood pressure is normal, her heart rate is high, and you learn that the patient's hot flashes occur mostly when she's working in a really warm environment in a greenhouse. She also reports diarrhea and unattended weight loss, and her last menstrual period was supposed to be 3 weeks ago, but it didn't happen, and she's had several skipped or light cycles recently. She has been using barrier contraception, is not pregnant, so we don't have to worry about that. So the next step that you should think about is ordering labs, specifically T4 and TSH. And for both thyroid disorders, we want to look at antibodies to see if there is any autoimmune portion of that, so we'll order that antibody test as well. So all of these here in red are signs and symptoms of hyperthyroidism. Her lab results came back with high T4 and low TSH and a positive antibody test, which means she likely has Graves' disease that is leading to her hyperthyroidism. The next thing I want to look at is the patient on any medications that might cause those symptoms of hyperthyroidism. These medications can cause hyperthyroidism and change the levels. These are iodine, either from dietary sources or from contrast, and this is in excess of your normal intake. Also, amiodarone and interferons can cause hyperthyroidism, but they can also cause hypothyroidism, so be careful with those. And then thyroid hormone replacements, if you overshoot, you can cause hyperthyroidism symptoms. As you see on the clipboard here on the right-hand side of the screen, the patient is only on an albuterol inhaler and ibuprofen. These medications are not on our list of things that can cause hyperthyroidism, so we don't have to worry about this. So there are a few medications that we can use to manage chronic hyperthyroidism. The first one is beta blockers. These are used primarily for symptom control, specifically for high heart rate, palpitations, sweating, and tremors. Beta blockers are recommended for all patients who have symptoms and want symptomatic control, but specifically for those patients who have a heart rate above 90 or those who have some sort of underlying cardiovascular disease. Beta blockers can cause fatigue, hypotension, and exercise intolerance, so these are reasons why patients who do not meet those criteria may not want to try beta blockers for symptom control. The next medication to look at are the thionamides, which block production of thyroid hormone. These are propylthiouracil or PTU and methimazole, also known as tapazole. Methimazole is your preferred agent for most patients. The only time PTU is preferred is in first trimester of pregnancy. These drugs are very hepatotoxic. Specifically, PTU is more hepatotoxic than methimazole. They can cause something called drug-induced lupus, which causes a rash, specifically like a butterfly rash or those patchy rashes on your arms and legs, sometimes on your face. They also cause GI upset, so recommend that your patients take it with food. And patients will be on a high dose of these for about 1 to 3 months, and then the doses will be reduced after that to a maintenance dose. That way we don't push our patients into hypothyroidism. So let's take a look at where these work in our... So as you can see, here's our hyperthyroidism diagram. Our thionamides work by preventing the oxidation of iodine from the diet to iodide. PTU also helps prevent the conversion of T4 to T3 in the periphery. This way, we have less thyroid hormones circulating, and then our T4 levels will go down back to normal, which means that our TSH levels will rise again due to that inhibition of the negative feedback. Iodides are the next medication, and these are solutions called Lugol's, SSKI, or Thyrosave. These inhibit the secretion of thyroid hormone. These must be diluted with water, and you want to have your patients take them with food because they can be upsetting to the stomach. And these might cause a metal taste for patients, so that's something to remind them of when they pick it up. Iodides work by preventing the secretion of T3 and T4 from the thyroid into the blood. This causes less circulating T4, which in turn again lowers T4 levels and increases TSH levels through that negative feedback loop. There are 2 other treatments for chronic hyperthyroidism. The first one is radioactive iodine. This destroys part of the thyroid. The role of the pharmacist here is to remember to let patients know that they need to take their potassium iodide as soon as possible after the procedure to block the iodine uptake, which will prevent those nasty side effects from the iodine. The dose of the potassium iodide and the radioactive iodine is based on age and radiation exposure, and there are calculators online specifically from the CDC that you can use to dose those if you find yourself in that situation. And then patients may also have surgery to remove part of the thyroid, and in this case, they'll be on the thionamides temporarily before their surgery. So you can see here, surgery will take a part of the thyroid out, and then radioactive iodine will take a part of the thyroid out as far as making it non-productive. This in turn decreases circulating T4, which then increases TSH through that negative feedback loop. So let's look back at our patient HT. What is our plan for her? So our goals overall are to resolve the symptoms and help her achieve euthyroid state using medications. And I have those goal levels listed there for a free T4 of 0.8 to 1.5 and a total T4 78 to 195. We also want to minimize those long-term consequences. So the first thing we'll do, if the patient is agreeable, is to start the patient on a non-selective beta blocker for symptom control. She is recommended to have this because her heart rate was over 90, both resting. Propranolol is one of those non-selective beta blockers along with labetalol, but propranolol penetrates the central nervous system, so it's best for this purpose. You want to dose this in a range of 30 to 160 milligrams per day, and you can use immediate release or extended release, and you want to adjust the dose to heart rate and blood pressure. So for this patient, we'll use propranolol 10 milligrams dosed 4 times daily, and then we'll titrate it to her heart rate and blood pressure and her symptom control. We'll have her monitor her heart rate and blood pressure at home with an automatic blood pressure cuff, and we'll educate her on orthostatic hypotension, exercise intolerance, and the slight potential for the interaction with her albuterol, although she does use it infrequently, so that shouldn't be a problem. But albuterol can increase your heart rate, so that's something to look out for as well. So HT might be a candidate for surgery or radioactive iodine, but should be treated with anti-thyroid medication until a further plan is determined. So methimazole, again, is the drug of choice due to hepatotoxicity with PTU. We'll dose it as 5 milligrams every 8 hours initially until euthyroid, and then maintain a 5 to 15 milligram daily dose for 1 to 3 months. After that, you'll decrease the dose to prevent hypothyroidism, or you'll wean the patient off before surgery or the radiation treatment. With these drugs, you want to monitor your thyroid levels every 4 to 6 weeks until euthyroid, and then every 1 to 3 months thereafter. Also monitor your blood counts, LFTs for the liver damage, and the prothrombin time, especially before surgery. You also want to educate your patient to self-monitor for liver toxicity symptoms such as abdominal pain, yellowing of the skin and eyes, or dark urine, or signs and symptoms of infection. So let's look at what if HT was pregnant. So treatment for hyperthyroidism kind of depends on which trimester the patient is in. So PTU is recommended for the first trimester because methimazole has an increased risk of fetal abnormalities. Methimazole then is recommended for the second and third trimester because of that increased risk of severe liver injury with PTU. So remember, you might have to switch your patient back and forth twice depending on what they are on before pregnancy. All right, so HT presents back to clinic in 1 month, and she reports that she has a loss of taste. She's concerned because of the current pandemic, but she hasn't had any positive contacts, no symptoms of infection, and she tested negative for COVID 3 days ago. What could be the cause of this? So since we started the patient on a thionamide, we want to take a look at those side effects of those. So PTU and methimazole can cause loss of taste or taste perversion. This is a normal side effect, and we want to counsel our patients that it might be something to look out for, especially now during the time of COVID. Also counsel your patients on other signs and symptoms of COVID and those proper prevention techniques like hand hygiene, social distancing, and masking. That way they can prevent infection and they don't have to worry about the loss of taste. So now that we've looked at chronic hyperthyroidism, let's take a look at thyroid storm briefly. Thyroid storm is a life-threatening severe hyperthyroidism state that's usually precipitated by some sort of event like infection, trauma, surgery, the radioactive iodine treatment, or even medication non-adherence. So you have a patient with thyroid storm. They come in and they have exaggerated symptoms of hyperthyroidism. You want to treat them with an anti-thyroid drug like PTU, and you want to give that at least 1 hour before the iodide therapy. Then you'll give them an iodide, beta blocker, systemic steroid, and then you'll start your aggressive cooling protocol with Tylenol and cooling blankets. You'll also give your patients fluids and electrolytes. I don't want to go into the doses on this, but just remember that it's important that we're doing both the anti-thyroid drugs and the iodide, as well as beta blockers and all sorts of other things to make sure that the patient is able to come out of that severe hyperthyroidism state. All right, so that's hyperthyroidism. Let's briefly look at hypothyroidism. So again, here's those symptoms. Typically, they're the slow symptoms: cold intolerance, weight gain, constipation, depression, and low heart rate. So here's a diagram again. This time we're looking at hypothyroidism, specifically primary hypothyroidism. The most common cause of this is Hashimoto's disease, which is again an autoimmune disorder that causes autoantibodies to attach to the thyroid gland, and this time it causes a decrease in production of T3 and T4. This leads to an increased amount of TSH, so your labs will show a high TSH and a low T4. If you happen to see a low TSH and a low T4, This is due to something with either the hypothalamus or the pituitary gland, and that is actually secondary hypothyroidism. We're not going to talk about that much more today. So for hypothyroidism, we'll briefly go through this. So your goals are to resolve symptoms and get your TSH and FT4 in range. So your TSH range is 0.25 to 4.12, and your free T4 is 0.8 to 1.5. Levothyroxine is the drug of choice supported by the ATA guidelines. Make sure your patients have a consistent preparation, and make sure that they're educated about drug interactions and administration. Some patients say that they are better controlled on liothyronine or desiccated thyroid hormone, but these are not recommended by the guidelines. If you have patients on these, remember that Armour Thyroid is dosed in grains, and I have the conversions between grains and milligrams below. Your patients don't need to be on iodine supplements because there's iodine added to the salt in the US. If they believe that they need more, consider a multivitamin with iodine, especially if they have a decreased salt intake or don't use iodized salt. Here's a diagram showing you the different colors of the Synthroid tablets, which is universal between all the brands, even the generics. And then we have the dosing information here. So your 1.6 mics per kg per day. You do a little bit lower of a dose if they're elderly, if they have cardiovascular disease, and if they're elderly and have cardiovascular disease, you go a little bit lower even. So let's look at LT. LT is a 38-year-old female who's currently being treated for hypothyroidism with methimazole. She started it 6 weeks ago, and at week 2 of therapy, she had her labs checked and they were within normal limits, and she was euthyroid, which is awesome. But recently, LT started to notice that she was gaining weight and that her menstrual periods became heavier. She also noticed that she gets cold very quickly and her skin is a lot more dry than usual. She also recently saw a psychiatrist for new onset depression. So there are some things that lead me to believe that maybe this patient is experiencing symptoms of hypothyroidism. The patient gets cold quickly, her skin is dry, she's experiencing depression, and also she's on methimazole, so if we overshoot, we can definitely push her into hypothyroidism. She's in that 1 to 3 month window where she may be an appropriate candidate to lower her dose. So we already talked about this. The potential cause of the symptoms is overtreatment. We want to assess her adherence and make sure that the patient's not taking any extra doses, and then consider reducing the dose since the patient has been on treatment between 1 and 3 months. Hypothyroidism treatment in special populations is a little bit different, so remember in pregnancy we increase our dose and in the elderly we reduce our dose. So in pregnancy you'll continue levothyroxine, it is safe, but you'll need to increase the dose 30 to 50%, and this will continue several months postpartum. There are different goals for different trimesters as far as TSH levels go, so keep that in mind as you're managing your patients. In the elderly, make sure you reduce your dose because too high of doses can cause AFib and fractures. And keep in mind that your goals look a little bit different for these patients than they do for your typical healthy adult. And finally, let's look at managing myxedema coma, which is the acute emergency situation due to untreated hypothyroidism. These symptoms include poor circulation, hypothermia, hypometabolism, just basically exaggerated hypothyroidism symptoms. Treat these patients with IV levothyroxine. You can also give them supportive measures like fluids and warming, electrolytes, all of those things, but the IV levothyroxine is the most important part of this treatment. So let's review what we talked about today. Thyroid disorders often go undiagnosed. Screen patients over 60 years old and consider screening females with autoimmune disorders earlier on. There is no consensus as to when you should screen a patient, but if you have a patient with symptoms, make sure that this is something that you include in your differential. Thyroid function is regulated by a negative feedback loop between the hypothalamus, the pituitary gland, and the thyroid gland. The main causes of thyroid disorders are Graves' disease for hyperthyroidism and Hashimoto's disease for hypothyroidism. Both of these are autoimmune, where antibodies stimulate the production of or reduce production of the thyroid hormone, respectively. The preferred treatment for hyperthyroidism is methimazole, except during the first trimester of pregnancy when we use PTU. Thyroid storm, we want to use PTU plus all of our other treatments like iodides, beta blockers, etc. Levothyroxine is our drug of choice for hypothyroidism and for myxedema coma. And just remember that in pregnancy, we're going to increase our dose but not change our drug. So that wraps up our presentation today. Here are my references. And here are the image sources I used for the clip art throughout the presentation. If you guys have any questions, you can email me. My email is amelia.godfrey@mail.umkc.edu. At the end here, I went ahead and put those 2 slides with all of the pathophysiology and pharmacology on them. I'll leave them up on the screen for a few seconds each. That way, if you want them, you can screenshot them.